Okay, so this is the basis, okay? So this is how all your waves are, all right? So the the way the impulse originates in the heart is you have an SA node. From there, like we said, right, there are several pathways or like several conduction pathways which are connecting one part of the heart to the other. So the SA node sort of fires or depolarizes. From there, the impulse goes to the AV node. Now, this is just one pathway, but eventually what it does is it will depolarize the atrium. So it will depolarize the right atrium followed by the left atrium using some cell-to-cell transmission and some of those pathways, okay, the insulated cables we were talking about. Now, eventually, the whole of the atrium depolarizes and gives rise to one electrical vector, which then you see on the ECG as a P wave. Now, this ECG, this thing that is drawn here, think about it as lead 2, okay? So the way lead 2 is cutting the heart is at a 60-degree angle. So, yeah, do you just want to draw lead 2? Yes. So as you can see, the impulse is going from the top of the heart to the bottom of the heart. So from SA node to the AV node, and then in the direction of lead 2. So in direction of lead 2, you have an upright wave, which is atrial depolarization, which is your P wave, right? Then once it reaches the AV node, then it takes some time and then it goes on to the other pathways. Now that area in the AV node, before it depolarizes the ventricle, what you have is this PR segment, okay? And then I don't know if there are advanced, I don't know if it's just medical students. Okay, all right. And then what you have is from the AV node, then impulse goes through the bundles, okay? So there are two bundles, or there's one main bundle which is called bundle of His, and then it divides into two sides, the left and the right. And the left again divides into an anterior, and an anterior bundle and a posterior bundle, okay? So anterior fascicle, it's called a fascicle, and then you have the posterior fascicle. And then on the right side, usually when the impulse comes from top to bottom, comes down the bundle of His, it goes down both the bundles and then it depolarizes the rest of the heart. And we will talk in detail why do we see different the QRS waves. We have a section on that. But what you eventually get is a QRS complex. Q is the negative deflection, R is the positive, and S is the second negative. And we will tell you exactly why you see the QR and S later. And then there is eventually, once the ventricle depolarizes, you will have the ventricular repolarization, okay? So now the ventricle is depolarizing from top to bottom, and so what you get is a predominant positive R wave in lead 2. Now, the ventricular repolarization, okay, is seen in the form of a T wave. Now, a question you should have, or you might have, is if depolarizing is from top to bottom, the, the repolarization should ideally be in the opposite direction, right? And T should be negative, but the T is positive. Why? Because the depolarization happens from the endocardium, which is the inner lining of the heart, which goes on to the outside of the heart, which is the epicardium. Okay, so even though the heart is depolarizing from inside to outside, when it starts repolarizing, it repolarizes in the opposite direction. Instead of repolarizing in the opposite direction, it repolarizes in the same direction, which gives you the T wave, which is in the same direction of the QRS. So just remember, T wave should, for the concept, yes, but the basis is that T wave should usually be in the same direction as your QRS. Predominantly, the T's should be in the same direction as your QRS based on whatever lead you're looking at. So P, QRS, and T. P from P is the atrium part. The PR, like the PR segment, is where it stops in the AV node. The QRS is your ventricular depolarization, and then ultimately T is your ventricular repolarization. And this just highlights the fact that every area of the heart is capable of generating an impulse. It's called automaticity, as you all would have already heard, okay? It is just that the SA node basically has the highest rate of firing, and it takes over the other areas. Okay, so it's usually around 70, which gives rise to your sinus beat. But as you go lower down, even though all of these areas are capable, almost all of these areas are capable of generating their own heartbeats, but the sinus node is more predominant. Now, why is this important? Because let's say there is a problem up top, right? There is a problem in anything up top. Even the lower areas in the heart are capable of taking up your heartbeat, and that is why when we talk about complete heart block, when we talk about other things, you still see a ventricular impulse, okay? Because somewhere something is firing and causing your ventricles to beat.
So revising the same thing again, when the SA node fires, the firing is not recognizable. When the atrial muscle depolarizes, what we see is the P wave. The PR interval is usually caused due to the delay at the AV node. And this is the time when everything else is also depolarizing, but this is not recorded. The bundle of His gets depolarized, the right bundle branch and the left bundle branch gets polarized, but this does not get recorded. When the depolarization of the ventricular muscle mass happens, that's when we get the QRS complex. When the ventricular muscle mass repolarizes, that's when we get the T waves. And when the ventricles repolarization is happening, or it's the last or the terminal Purkinje fibers that are repolarizing, we get what is called the U wave. So again, we will see more on this. So this is just an animation which will tell you exactly how this is happening. So we find the SA node. You can see the SA node right here. And the SA node has got the highest automaticity to fire. From the SA node, the impulses will travel to the AV node. And if you see this, this is how at this point of time you will get the generation of P wave while this is there. And then the impulse has a delay at the AV node, and that's when you get the PR interval. So while the impulse is sitting at the AV node and there is a delay in transmission, that's when you get the PR interval. We will drop this for the moment. This was showing you how the conduction of the heart happens, how is the excitation happening with the movement of the potassium and the sodium ions in phase 0. Phase 1 is the calcium ion movement, and phase 3 is the potassium ion movement. And that's how the conduction of these ions is happening. And in this was the at the simultaneous recording of the QRS complex and ECG as this is progressing. So now we have the P wave which has already come. Let's talk about the QRS complex. So before that, I will talk about two things. I want to ask you in a poll now. I'm going to throw open a poll to you. How many of you know what is a scalar quantity and what is a vector quantity? So I've launched a poll now. Just answer in yes or no. If you know about scalar and vector quantities, I will not go into the detail of it. If you do not know, then I will have to address the scalar quantity and vector quantity in more depth. So I see that a lot of you, almost 90% of you already are familiar with what is a scalar quantity and a vector quantity. So I'm not going into a great detail. Sufficing here to say that a scalar quantity has only got magnitude, whereas a vector quantity has got a magnitude plus a direction. So whatever recordings of the ECG is happening, or whatever recording of the electrical activity of the heart is happening, is basically due to the vectors of the electrical current that are being formed in the heart. So to understand what is happening on QRS, it's most important that you do understand that this is governed by these three vectors. This is the septal vector for the septum. So this is the septum of the heart. Then you have the vector for the left ventricle. This is the left ventricle wall of the heart. And you have the terminal vector, which represents the polarization, depolarization of the right ventricle of the heart. So this is the direction of the septal vector. So if you remember from what we were discussing a little while earlier, if you let's take this color. If you remember the heart Einthoven's triangle, that's lead 1, and you have lead 2, and you have, this is lead 2, and you have lead 3. So this was 60 degrees. If you look at this, the direction of, you will be able to see the vector directions and how this will proceed in different leads. So that's the septal vector, and this is followed by the LV vector. The left ventricular vector goes in this direction, and you have the right ventricular or the terminal vector, which travels in this particular direction. That's how the summation arises. So again, this is the septal vector forming here. This is the vector in stage 2, which is giving rise to the rise in the R wave, and this is the vector for the left ventricle, which is now ebbing, and that's why the current is coming down. So the recording is coming further down, and that's the terminal vector recording, and then you get the small recording here. So if we again look at the animation of how this moves, so as the vectors are forming and as the current is flowing into the Purkinje system, this is practically what you will be recording on this side on the ECG last. So if you don't understand this very well, please don't be really bothered, but do remember that the QRS complex is formed because of the summation of 3 vector forces that are acting inside the heart: the septal vector, the left ventricular vector, and the terminal vector, which is indicating the right ventricular depolarization. So what happens to the T wave? The T wave is formed by the ventricular repolarization. There is QRS, which is occurring prior to the systole. However, the repolarization, when it is happening, listen to this carefully, when the repolarization of the ventricles is happening, that's when you get the T wave. That's one part of it. But at this time, there is an increased pressure gradient across the ventricle wall. Also, this is an energy consuming process because the repolarization is happening against the electrical gradient. Ionic shifts, or the sodium, potassium, and calcium, have to follow against the electrical gradient of the heart, and this requires the consumption of the ATP. So that goes on to say that if there is any physiological or metabolic or hemodynamic change, it will produce abnormalities of the T wave. So T wave has got a lot of potential to be changed by any metabolic abnormalities. Another thing, so when you are looking at an ECG for metabolic abnormalities, the area of the ECG that you need to look at is the T wave. Anything can change it: exercise, eating, ice water, infection, fever. So in fact, Levine listed 67 causes which can actually cause changes in the T wave morphology and the T wave recording. But we are not going into those details. So to summarize, the P wave represents the atrial depolarization. QRS complex is the ventricular depolarization. T wave is the ventricular repolarization. So if the ventricle is depolarizing and then it is repolarizing, what happens to the atrial repolarization? This is again now going to come up in a poll for you, and you would need to answer that on your screens. So which wave do you think is recording the atrial repolarization of the ECG?
Yeah, so basically the atrial repolarization, the atria have a very small muscle mass. So another concept that we need to know here is that the magnitude of the wave depends on the musculature, how much musculature is in the myocardium. So atria have a comparatively lighter musculature, or the musculature is less as compared to the ventricles. So the waves are expected to be smaller. That is why the P wave is smaller than the QRS. And the atrial repolarization, what happens is that it coincides with the ventricular depolarization. So that wave is supposed to be somewhere superimposed or somewhere happen at the same time when we have the QRS complex. But since the ventricular musculature is more compared to the atria and the QRS is the dominant wave on ECG at that time, so that is why the wave generated during atrial repolarization is hidden. So what we see is just the QRS.
Thank you, Prabhat. So exactly, the E wave or the atrial repolarization gets buried in the QRS complex. Manav, you were asking something. Why don't you go ahead and ask now?
Sir, I just wanted to ask if you could briefly explain about the three vectors causing the QRS complex. I mean, just the direction.
I think vector cardiography में अभी नहीं जा पाएंगे because vector
Okay,
cardiography
sure,
would
sir.
take another 1 hour. So let's drop
Because
that.
that would be something more complex or long time taking.
Advanced class में.
Okay, sir.